Let's go through this case, which is derived from a series of images from an intravenous urogram, IVU. In this specific case, the films are labeled release, meaning the study was performed with compression to highlight the renal collecting systems and ureters. As I review the initial control film, I can't identify any obvious renal tract calcification. However, there's quite a lot of bowel gas, which makes the nephrograms less clearly seen after contrast administration. Now, one significant finding here is a filling defect located in the left inferior side of the bladder. This is the key abnormality on this study. However, no other notable issues are identified within the pelvic lyceal systems or the ureters on the provided images. But I would want to review other available films to make sure that nothing's being missed due to incomplete visualization in these images. Given the filling defect in the bladder, my differential diagnosis would strongly lean towards a bladder tumor, particularly transitional cell carcinoma, TCC, which is known to present this way on an IVU study. If I were writing the formal report, I'd definitely be advising correlation with the patient's clinical history to help support this diagnosis. For further management, I'd recommend an immediate discussion with the urology multidisciplinary team for more in-depth evaluation. Direct visualization via cystoscopy and potentially a biopsy would likely be the next steps to confirm the presence of a tumor. If the lesion turns out to be a tumor, staging would likely require a CT scan. Now, if the examiner were to probe further and ask what other differential diagnoses could cause a filling defect on intravenous urography, I'd point out that filling defects can sometimes result from technical issues. For example, the overlapping bowel gas seen in this film can mimic a defect. Other extrinsic causes, like compression from a cyst or even tumors external to the urinary system, can also contribute. However, when the defect is located intraluminally, like in this case, other causes like a clot, debris, or polyps can present with similar imaging features. But I'd emphasize that in a case like this, TCC remains the most likely diagnosis, especially when considering the patient's risk factors or history of bladder irritation or industrial exposures, such as to dye manufacturing. A bladder tumor like TCC is the most common malignancy of the genitourinary system, especially in the bladder. It's more frequently observed than upper tract TCCs, although those can coexist. Occupational history is an important factor for risk, particularly in individuals exposed to chemicals in certain industries. It's also worth mentioning that bladder TCC is common in certain geographic areas, like Egypt, where schistosomiasis-related chronic inflammation predisposes individuals to this condition. In practice, we frequently encounter bladder TCCs on CT urography, but the classic IVU remains a relevant film type for the FRCR Viva examination. As we wrap up this case, it's important to stress the significance of the filling defect in the context of a bladder tumor and the next steps that would involve urological input and potentially further imaging or intervention. I'd conclude this Viva by saying that if you found this breakdown useful, please subscribe to Radiology Made Easy. If you have any similar cases or questions, don't hesitate to drop a comment. Let's keep learning together.